Okay, let's unpack this. Welcome back to the deep dive.
Today, our mission, well, it's pretty intense. We're not just skimming the surface of hemostasis pharmacology. We're aiming for mastery, like true elite professional understanding. That means getting deep into the molecular gears, understanding why these drugs work, their specific quirks, half-lives, how to reverse them, how they interact. Because getting this right, it's life-saving. Getting it wrong, potentially catastrophic.
Absolutely. It's high stakes. We've taken the source material you provided and really tried to build a framework for that deep understanding. It's not just about knowing that heparin works, but how it interacts with antithrombin III and why that's different from, say, how apixaban works.
Exactly. And understanding why you choose one over the other based on everything from kidney function to someone's genetic makeup.
Right. So before we jump into the drugs themselves, the ways we interfere, let's just quickly set the stage, define the system we're trying to control. Okay, so hemostasis fundamentally, it's just the body stopping bleeding. Simple enough on the surface, but the reason we need these drugs is usually the flip side of that coin, isn't it?
It is. The big medical challenge we're usually tackling is thrombosis. Pathological thrombosis. That's an unwanted clot forming inside a blood vessel.
And that leads to the big killers. MI, DVT, PE, stroke.
Precisely. Acute MI, deep vein thrombosis, pulmonary embolism, ischemic stroke, these are all consequences of thrombosis. Major public health issues.
Okay, terminology check for the pros listening. Thrombus versus embolus, we use them a lot. What's the critical difference?
Good point. A thrombus is stationary. It's a clot stuck to the vessel wall, often develops on, say, an atherosclerotic plaque. An embolus, on the other hand, is mobile. It's usually a piece of a thrombus that's broken off or some other intravascular material floating in the blood.
Until it gets stuck somewhere smaller downstream.
Exactly. It travels until it wedges itself, causing blockage. So both occlude vessels, but the embolus is the traveler, the migrating threat.
And this might seem basic, but it dictates everything that follows. The difference between arterial and venous clots. Are they really that distinct?
Oh, absolutely. From a treatment perspective, critically distinct. Arterial thrombosis usually happens in high-flow systems. Think coronary arteries, cerebral arteries. It's often triggered by plaque rupture.
And because of that high-flow, high-shear stress.
It's primarily driven by platelets. Platelet activation, aggregation, that's the main event. So these clots are typically platelet-rich, which is why antiplatelet drugs are the cornerstone here.
Makes sense. And venous clots, like a DVT in the leg?
That's typically venous thrombosis. Occurs in low-flow situations. Think Virchow's triad stasis, maybe hypercoagulability, endothelial injury.
Yeah.
Here, the coagulation cascade itself generating fibrin is the dominant process.
So these are fibrin-rich clots.
Exactly. And that's why our main strategy for VTE, venous thromboembolism, relies heavily on anticoagulants drugs that target that fibrin-forming cascade.
Right.
Understanding that fundamental difference, platelet-rich versus fibrin-rich, arterial versus venous, that's probably the first key unlock to mastering this whole area.
Right. If the main enemy in arterial disease like MI or stroke is that platelet plug, then we absolutely need to understand how that plug normally forms before we talk about how to stop it. Let's dissect that normal platelet response.
Okay. So in the normal state, platelets are just circulating, kind of like sentries. They're kept quiet, inactive, largely thanks to a healthy, intact endothelium, the lining of the blood vessel.
And that endothelium is actively producing stuff to keep them calm.
Exactly. It releases things like nitric oxide, but crucially for this discussion, it makes prostacyclin, or PGI2. Think of PGI2 as the natural, keep moving, nothing to see here signal for platelets.
How does it deliver that signal molecularly?
PGI2 binds to specific receptors on the platelet surface. This kicks off a signaling cascade inside the platelet that leads to the synthesis of cyclic AMP, or CalMP.
CAMP, the classic second messenger.
Right. And the key effect of increased TNMP in a platelet is that it leads to a decrease in the concentration of free calcium inside the cell.
And keeping intracellular calcium low is critical for keeping the platelet dormant. Why?
Because calcium is basically the go signal for platelet activation. When calcium levels are low, several things happen. Crucially, the main receptors responsible for aggregation, the glycoprotein IB receptors, stay in an inactive shape. They can't grab onto fibrinogen.
Okay.
Low calcium also prevents the platelet from releasing its internal stores of activating chemicals, the granules, and it stops the synthesis of thromboxane E2. So low calcium equals inactive platelet. It's the body's way of preventing spontaneous clotting.
So injury disrupts this. Physical trauma, plaque rupture, that breaks the equilibrium. What's the first response?
Vasospasm, the vessel constricts. But then, crucially, the platelets encounter stuff they normally don't see. Exposed collagen fibers in the subendothelium von Willebrand factor.
And sticking to that collagen is the trigger.
That's the initial spark. Platelet adhesion to exposed collagen immediately triggers platelet activation.
And an activated platelet isn't just sticky itself, it calls for backup, right? It releases that chemical storm.
Precisely. It changes shape, gets spiky, and degranulates, releases potent signaling molecules from its internal stores. We're talking ADP, thromboxane A2, TXA2, serotonin, platelet activating factor, a whole cocktail.
And these chemicals then activate other nearby platelets.
Exactly. ADP binds to P2Y12 receptors on adjacent platelets. TXA2 binds to its receptors. It's a recruitment drive. This positive feedback loop is what creates that avalanche effect. A few activated platelets quickly recruit and activate many, many more.
Okay, let's zero in on that avalanche. What specifically drives the aggregation, the actual clumping together?
It comes back to calcium. That initial adhesion and activation causes a massive, rapid increase in cytosolic calcium released from internal stores. This calcium surge does three key things almost simultaneously.
Okay, what are?
One, it triggers that granular release we just talked about, releasing more ADP, serotonin, etc. Two, it activates the enzymes needed to synthesize new thromboxane A2, further amplifying the signal.
Right.
And three, this is the big one, it causes a conformational change in those glycoprotein IB receptors.
Flipping them from off to on.
Exactly, from a low affinity state to a high affinity state, ready to bind.
And that binding involves fibrinogen, acting like molecular glue.
Precisely. The activated GP-IB receptor is often called the final common pathway for aggregation. Why? Because the soluble protein fibrinogen, which is always present in the plasma, can now bind to these activated GP-IB receptors. And here's the key. One fibrinogen molecule can simultaneously bind to GP-IB receptors on two different activated platelets.
Ah, so that's the cross-linking. That's what physically holds the plug together.
That's the physical aggregation, yes. It welds them together. Then, local factors generate thrombin, which converts that fibrinogen into insoluble fibrin strands, creating a mesh that reinforces and stabilizes the whole platelet plug.
Okay, that's a beautifully complex, self-amplifying system. So if that's the problem in arterial thrombosis, now, here's where it gets really interesting, part two. How do we therapeutically jam the gears? Let's talk antiplatelet agents, starting with the oldest, maybe the most elegant, aspirin.
Aspirin is, it's pharmacologically fascinating, mainly because of its irreversibility. It targets TXA2 synthesis.
Remind us of that exact molecular step. Why irreversible?
So aspirin performs an irreversible acetylation. It permanently sticks an acetyl group onto a specific serine residue right in the active site of the enzyme cyclooxygenase 1, or COX1.
And blocking COX1 stops it from making TXA2.
Correct. COX1 is the enzyme that converts arachidonic acid into precursor molecules for thromboxane A2. By acetylating it, aspirin permanently shuts down that enzyme's ability to make TXA2 within that platelet.
Right. And here's the critical link for professionals. That irreversibility ties directly into the platelet's own biology.
That's the absolute key. Platelets are basically just cell fragments. They have no nucleus, no DNA. They can't synthesize new proteins, including new enzymes. So once aspirin acetylates that COX1 molecule,
it's out of commission for good.
For the entire remaining lifespan of that specific platelet, which is typically 7 to 10 days.
And that's why we hold aspirin for 5-7 days before surgery, right? It's not about the drug clearing the system. It's about waiting for new, unaffected platelets to replace the old ones.
Exactly. It's cell biology dictating clinical practice. Therapeutic use is widespread, preventing TIAs, recurrent MIs, primary and secondary MI prevention. And you achieve pretty much full antiplatelet effect with low doses. 81 milligrams daily is standard, though doses up to 325 milligrams are sometimes used.
Let's hit that specific, crucial interaction with ibuprofen. This catches people out.
Yeah, this is important, especially with over-the-counter use. Ibuprofen, like other NSAIDs, is also a COX1 inhibitor, but crucially, it's a reversible one. So if a patient takes ibuprofen before their immediate-release aspirin, the ibuprofen molecule can temporarily sit in that COX1 active site, blocking access.
Physically obstructing aspirin from getting in.
Right. When the ibuprofen eventually lets go, the site is open again, but the aspirin might have already been absorbed and cleared, missing its chance to irreversibly acetylate that specific enzyme molecule. The net effect is reduced antiplatelet efficacy from the aspirin dose.
So the clinical advice is all about timing.
Yes. To ensure aspirin gets first dibs on that COX1 site, take immediate-release aspirin at least 60 minutes before taking ibuprofen, or wait at least 8 hours after taking ibuprofen. Give the aspirin clear access.
Okay, moving downstream in the activation cascade, the P2Y12 receptor antagonists, the ADP blockers, these hit that amplification loop hard.
They do. They prevent ADP, released from activated platelets, from binding to the P2Y12 receptor on other platelets. Blocking this signal prevents the downstream activation of the GP-IBA receptors. We generally group them into two types based on how they bind.
Irreversible versus reversible.
Exactly. The irreversible ones are mostly prodrugs: ticlopidine, clopidogrel, prasugrel.
Let's focus on clopidogrel Plavix first, very widely used, but with a major catch.
The catch is that clopidogrel itself is inactive. It's a prodrug. It has to be metabolized primarily by a liver enzyme called CYP2C19 into its active form. Only that active metabolite can then irreversibly bind to and shut down the P2Y12 receptor.
And that dependence on CYP2C19 creates a huge clinical issue, genetic variability.
Absolutely. This is pharmacogenetics in action. There's significant genetic polymorphism in the CYP2C19 enzyme. A chunk of the population, varying by ethnicity, are poor metabolizers. Their enzyme just doesn't work well.
Meaning they don't convert enough clopidogrel to its active form.
Correct. They get a reduced antiplatelet effect, leaving them at higher risk for clotting events like stent thrombosis after PCI. For these patients, we might need genetic testing and definitely need to switch to an alternative agent that doesn't rely on CYP2C19, like prasugrel or ticagrelor.
And it's not just genetics. Other drugs can mimic being a poor metabolizer, right?
Yes. Any drug that inhibits the CYP2C19 enzyme will also reduce the formation of clopidogrel's active metabolite. Classic example here is the proton pump inhibitors omeprazole and esomeprazole.
So using those PPIs with clopidogrel reduces its effectiveness.
Significantly, it's a critical interaction to avoid. If a PPI is needed, agents like pantoprazole, which have less impact on CYP2C19, are generally preferred.
What about the other irreversible P2Y12 inhibitors, ticlopidine and prasugrel?
Iclopidine ticlid was an earlier one, but its use is really limited now because of a nasty side effect profile. It carries a significant risk of severe hematologic reactions, specifically agranulocytosis, dangerously low white blood cells, and TTP, thrombocytopenic purpura. Clopidogrel was largely developed to avoid these issues.
Okay. And prasugrel?
Prasugrel, Effiant, is also a prodrug, but it's converted more efficiently and reliably than clopidogrel, leading to more potent and consistent P2Y12 inhibition. However, that potency comes with a higher bleeding risk. Its major restriction is that it's contraindicated in patients with any history of TIA or stroke, because studies showed an increased risk of intracranial hemorrhage in that group. It carries a black box warning for bleeding overall.
So more potent, but riskier in certain populations. Now, the reversible P2Y12 blockers, ticagrelor and cangrelor.
Right, ticagrelor Brilinta binds reversibly to the P2Y12 receptor. It's not a prodrug, so its onset is faster, and its effect wears off more quickly once stopped, which could be useful. It's often used in acute coronary syndromes.
But it has its own critical interaction nuance related to aspirin dose.
Yes, another key black box warning. Ticagrelor's effectiveness is actually reduced if the patient is taking concomitant maintenance doses of aspirin greater than 100 milligrams per day. So when using ticagrelor, you specifically have to keep the aspirin dose at 81 milligram typically.
Interesting. And cangrelor?
Cangrel, is the 5E option. It's a direct, reversible P2Y12 inhibitor with a very rapid onset and extremely short half-life. It's used almost exclusively during PCI procedures for immediate, potent, but quickly reversible antiplatelet effect.
Okay, so we've hit TXA2 synthesis with aspirin, ADP signaling with the P2Y12s. What about hitting that final common pathway directly? The GP-IBA inhibitors.
These are the real heavy hitters, the big guns of antiplatelet therapy. They directly target and block the GP-IBA receptor complex itself.
Preventing fibrinogen from binding and cross-linking platelets regardless of what activated them upstream.
Exactly. They shut down aggregation at the final step.
Who are the players here, and why are they only given 5V?
The main agents are ipsiximab, RioPro, which is a fragment of a monoclonal antibody,
Yeah.
eptidagatide, integralin, a synthetic peptide, and tirofibon, aggrastat, a non-peptide molecule. They are incredibly potent, and because of that potency and bleeding risk, they're administered intravenously, almost exclusively in the setting of high-risk PCI, as an adjunct therapy to prevent acute complications like abrupt vessel closure.
Any key differences between them?
Ipsiximab has a longer duration of action due to its antibody nature. Its effects can persist for 24-48 hours after stopping the infusion. Eptifibatide and tirofibon have shorter half-lives and are cleared more rapidly, primarily by the kidneys, allowing for quicker reversal of the antiplatelet effect if needed.
Right. Last category in the antiplatelet world, the phosphodiesterase inhibitors, dipyridamole and cilostazol. How do these work?
These work by indirectly boosting that natural inhibitory signal, CMP. They inhibit the enzyme phosphodiesterase, PDE, which normally breaks down CMP.
So inhibiting the breakdown means more CAMP hangs around.
Correct. More CAMP means lower intracellular calcium, which, as we established, inhibits platelet activation and aggregation. Plus, increased CAMP also promotes vasodilation.
Dipyridamole is often seen combined with aspirin, right, for stroke prevention.
Yes, the combination product, Agrinox, is commonly used for secondary stroke prevention. But dipyridamole comes with a very specific warning, particularly for patients with unstable angina. We need to talk about the coronary steal phenomenon.
Explain that. It sounds counterintuitive.
Dipyridamole is a potent vasodilator. In someone with healthy coronaries, it dilates all the vessels. But imagine a patient with severe coronary artery disease. They have a narrowed artery that's already maximally dilated just to get enough blood through. It can't dilate any further.
Okay.
When you give dipyridamole, it primarily dilates the healthy coronary vessels, the ones that can still respond. This actually diverts or steals blood flow away from the already ischemic area served by the diseased, non-responsive vessel and shunts it towards the healthy tissue.
Making the ischemia in the bad area worse.
Precisely. It worsens the oxygen supply-demand mismatch in the compromised myocardium. That's why dipyridamole is contraindicated in patients with unstable angina.
Wow, okay, critical point. And cilostazol, used for claudication.
Cilostazol, Predel, specifically inhibits PDE type 3. It's approved to improve symptoms of intermittent claudication leg pain with walking due to peripheral artery disease, largely through vasodilation and some antiplatelet effect.
But it also carries a major contraindication related to heart failure.
Yes, this is non-negotiable. The class of drugs, PDE3 inhibitors, were studied in patients with advanced heart failure, and they were associated with increased mortality. Therefore, cilostazol is absolutely contraindicated in patients with heart failure of any severity. That's a key safety point. It's also heavily metabolized by CYP enzymes, 3A4 and 2C19, so dose adjustments and interaction checks are important.
Okay, we've thoroughly dissected the platelet side. Now let's shift gears to the other major arm of hemostasis, the coagulation cascade. This is about stabilizing that initial plug with a fibrin mesh, and it requires a different set of drugs, the anticoagulants.
Right. The coagulation cascade is this complex series of enzymatic reactions. Think of it like a waterfall, where activating one factor leads to the activation of the next. It has two main initiating branches. The extrinsic pathway, kicked off by tissue factor exposure at the site of injury, activating factor 7, and the intrinsic pathway, triggered when factor 12 contacts exposed collagen.
And these two pathways eventually meet up.
They converge. Both pathways ultimately lead to the activation of factor X into factor XAN. Factor XAN is the crucial enzyme at the crossroads.
What does factor XAN do?
Its main job is to convert prothrombin, factor 2, into the master enzyme of coagulation. Thrombin, factor there. Thrombin is the real workhorse. It converts soluble fibrinogen into insoluble fibrin strands, activates factor 13 to cross-link those strands into a stable mesh, and also potently activates platelets, further amplifying the whole process.
The body must have brakes on this system, right? Otherwise we'd clot solid.
It does. A key natural inhibitor is a protein called antithrombin III, AT-TIE. And this is exactly where our first major class of parenteral anticoagulants, heparin and the LMWHs, exert their effect.
They leverage the body's own brake.
Precisely. Both unfractionated heparin, UFH, and low molecular weight heparins, LMWHs, work by binding to antithrombin III. This binding causes a conformational change in AT3 that dramatically speeds up its ability to neutralize key clotting factors, primarily thrombin and factor XAN. We're talking about a 1,000-fold acceleration, roughly.
Yeah. Okay, what's the difference between standard unfractionated heparin, UFH, and the low molecular weight versions, LMWHs, like enoxaparin?
It comes down to size and structure. Unfractionated heparin is a mix of long polysaccharide chains with varying lengths and a high negative charge. Its length is important. It's long enough to form a ternary complex, binding to AT3 and simultaneously grabbing onto thrombin, allowing AT3 to efficiently inactivate it. It also helps AT3 inactivate factor XAN.
But that structure leads to problems with predictability.
Big time. Because of its size and strong negative charge, UFH binds non-specifically to all sorts of things in the blood plasma, proteins, endothelial cells, platelets. This binding is variable and unpredictable between patients.
Which is why we have to monitor it closely.
Exactly. That unpredictable binding means we need frequent monitoring with the activated partial thromboplastin time, APTT, to ensure the dose is therapeutic but not excessive. It requires constant adjustment, especially in acutely ill patients.
Okay, so how do LMWHs improve on that?
LMWHs, like enoxaparin, Levinox, or dolteparin, fragment, are made by breaking down UFH into shorter fragments, about one-third the size. These shorter chains can still bind 83 and efficiently potentiate the inactivation of factors A. However, most LMWH chains are too short to effectively bridge 83 to thrombin.
So they mainly target factors A, less so thrombin.
Primarily factors A, yes. And because they're smaller and less charged, they have much less non-specific binding. This results in far more predictable pharmacokinetics and anticoagulant response.
Which means
Which means we can usually give them in fixed, weight-based subcutaneous doses, like once or twice daily, with minimal or no routine monitoring. This predictability is a huge advantage, especially for outpatient treatment of VTE.
you mentioned earlier they are preferred in pregnancy. Why is that?
Because both UFH and LMWHs are large charged molecules, they do not cross the placenta. This makes them the anticoagulants of choice when needed during pregnancy, as they won't affect the fetus, unlike warfarin.
Okay, but LMWHs aren't without their own critical pharmacokinetic issue, especially concerning elimination.
Right. This is crucial for safety. LMWHs are cleared almost exclusively by the kidneys. So, in patients with renal insufficiency, especially severe impairment, like a creatinine clearance below 30 LMN, the drug isn't cleared effectively.
It accumulates.
It accumulates, the half-life gets much longer, and the risk of major bleeding goes way up. So LMWHs must be dose-adjusted or often avoided altogether in severe renal failure. Sometimes, despite the hassle, UFH is preferred in that setting because its clearance is less dependent on the kidneys.
We absolutely have to discuss the most feared complication of heparins. HIT, heparin-induced thrombocytopenia.
Yes. HIT is a serious immune-mediated reaction. The body forms antibodies against a complex of heparin and a platelet protein called platelet factor 4, PF4.
And confusingly, despite the name thrombocytopenia, low platelets, the real danger is clotting.
Paradoxically, yes, those antibody-platelet complexes actually activate platelets, leading to widespread platelet consumption, hence the low count, but also a massively increased risk of venous and arterial thrombosis. It's a prothrombotic state. If HIT is suspected, you must immediately stop all heparin products, UFH and LMWH, as there is cross-reactivity, and switch the patient to a completely different type of anticoagulant.
Which brings us nicely to the alternative parenteral agents that don't rely on AT3. What are the options if heparin is out?
We look towards the direct thrombin inhibitors, or DTIs. As the name suggests, they bind directly to thrombin, factor 3, and inhibit its activity, without needing antithrombin III. Key players here are argatroban, bivalirudin, and dizarudin.
And argatroban has a specific role in HIT.
Yes, argatroban is often the go-to agent for anticoagulating patients who have confirmed or suspected HIT, precisely because its mechanism is independent of the heparin PF4 complex, a key professional detail for argatroban. It's metabolized by the liver. So unlike LMWH, you need to be cautious and potentially reduce the dose in patients with hepatic impairment.
Okay. And bivalirudin. Sounds familiar from the cath lab.
Bivalirudin and Jumax, and the less commonly used dizarudin are synthetic peptides based on hirudin, the anticoagulant found in leech saliva.
Huh. Modern medicine meets medieval leeches.
It's amazing, isn't it? Bivalirudin is used extensively during PCI, coronary interventions, because it's a reversible DTI. It inhibits both free thrombin and the thrombin that's already bound within a clot. That reversibility means its anticoagulant effect wears off relatively quickly after stopping the infusion, which is desirable in a procedural setting where bleeding control is paramount.
Right. One more parenteral before we go oral. Fondaparinux.
Fondaparinux, Orextra, is unique. It's a synthetic molecule, specifically the 5-sugar sequence, pentasaccharide, from heparin, that's responsible for binding to antithrombin III.
So it binds AT3, but what does it inhibit?
Because it's just that short binding sequence, it selectively potentiates AT3's ability to neutralize factors A very strongly, by 300 to 1,000-fold. It has virtually no effect on thrombin. It offers predictable kinetics, once-daily subcutaneous dosing, and is used for VTE prophylaxis and treatment.
But it shares a critical limitation with LMWH and has a major issue regarding reversal.
Exactly. Like LMWH, fondaparinux is eliminated almost entirely unchanged by the kidneys. Therefore, it is absolutely contraindicated in severe renal impairment, CRCL 30 LMN. And the big one, unlike heparin, which has protamine sulfate as an antidote, there is currently no specific reversal agent available for fondaparinux-associated bleeding. Careful patient selection is absolutely essential.
Okay, that covers the injectables. Let's transition now to the cornerstone of long-term anticoagulation for many conditions, the oral agents, starting with the classic, the challenging, the venerable, warfarin.
Warfarin, Coumadin, a vitamin K antagonist or VKA. Its mechanism is fundamentally different. It works in the liver by inhibiting an enzyme called vitamin K epoxide reductase.
What does that enzyme normally do?
It recycles vitamin K. It converts inactive vitamin K epoxide back into the active reduced form of vitamin K. This active form is essential for a crucial post-translational modification step.
The carboxylation.
Exactly. The gamma carboxylation of specific glutamate residues on several clotting factors. Factors 2, prothrombin, 7, niacin X, as well as the anticoagulant proteins C and S. This carboxylation step is required to make these factors biologically active, able to bind calcium and participate in the cascade.
So warfarin stops the recycling of vitamin K, starving the liver of the active form needed to activate these factors.
Precisely. It prevents the synthesis of functional factors 2, 7, NiAX, and X.
Now, the huge clinical implication, that incredibly slow onset of action, why does it take 72 to 96 hours, 3 to 4 days to really kick in?
Because warfarin only stops the production of new functional factors. It does absolutely nothing to the already functional factors that are currently circulating in the bloodstream. The anticoagulant effect only becomes apparent as these existing factors are naturally cleared and degraded according to their own biological half-lives. Factor 7 goes first, factor 2 lasts longest.
Which is why you often need to bridge with heparin or LMWH when starting warfarin, right? To get immediate anticoagulation while waiting for warfarin to take effect.
Exactly. That bridging is standard practice in acute settings like DVT or PE.
And managing warfarin. It's all about the monitoring and the interactions, isn't it?
Absolutely. It has a very narrow therapeutic window, meaning the dose needs to be just right. Too little, you clot. Too much, you bleed. So mandatory monitoring using the International Normalized Ratio, INR, is required, often frequently.
Yeah.
And the interactions.
It's metabolized by the liver's CYP450 system, right? Mainly CYP2C9.
Primarily CYP2C9, but other CYPs are involved too. This means its metabolism is highly susceptible to genetic variations and, importantly, interference by countless other drugs and even dietary changes, like vitamin K intake.
Can you give us some classic examples of interactions that dangerously raise the INR?
Sure. Drugs that inhibit CYP2C9, like the antifungal fluconazole, will slow down warfarin metabolism. Warfarin levels build up, INR shoots up, bleeding risk increases. Another mechanism, drugs that are also highly protein-bound, like certain sulfonamide antibiotics, can displace warfarin from its binding sites on plasma albumin. This increases the amount of free, active warfarin, again raising the INR.
And in interactions that lower the INR, increasing clot risk.
Those would be drugs that induce the CYP enzymes responsible for warfarin metabolism. Classic examples are afrompin, an antibiotic, or certain barbiturates. They speed up warfarin breakdown, lower the INR, and potentially lead to treatment failure and thrombosis. Managing warfarin is a constant vigilance task.
And the risks go beyond bleeding. Teratogenicity is a big one.
Huge. Warfarin readily crosses the placenta and can cause serious fetal harm, particularly bone and cartilage abnormalities, fetal warfarin syndrome. It is absolutely contraindicated during pregnancy. Other rare but serious issues include skin necrosis, especially early in therapy if protein C levels drop too fast, and purple toe syndrome, thought to be due to cholesterol emboli.
Okay. Warfarin complex, effective but challenging. This sets the stage for the modern revolution, the direct oral anticoagulants, the DOACs.
Right, the DOACs, sometimes called NOACs, non-vitamin K oral anticoagulants, really changed the landscape. Their big selling points were generally predictable pharmacokinetics, allowing for fixed dosing without routine INR monitoring, established efficacy compared to warfarin for many indications, and fewer food and drug interactions.
Let's break them down by target. First, the oral direct thrombin inhibitor.
That's dabigatran ataxilate, or DAXA. It's actually a prodrug that gets converted to active dabigatran. Like the parenteral DTIs, it directly and reversibly inhibits both free and clot-bound thrombin, factor time A.
What's its key pharmacokinetic feature we need to remember?
Renal clearance. Dabigatran is eliminated primarily by the kidneys. This is critical. Dose reduction is necessary for patients with moderate renal impairment, and it's often avoided in severe impairment. There's also increased bleeding risk noted in elderly patients, particularly those over 75, sometimes requiring dose adjustment.
And a common side effect.
GI upset, particularly dyspepsia, indigestion, or heartburn, is relatively common with dabigatran compared to warfarin or the factor VAD inhibitors. Sometimes taking it with food helps.
Okay. Now, the bigger class, the oral direct factor XA inhibitors, who's in this group?
This includes apixaban, Eliquis, rivaroxaban, Xarelto, edoxaban, Cevisa, and betrixaban,
Okay.
Afixa. They all work by directly binding to and inhibiting factor XA, both free and clot-bound.
So they shut down the cascade right at that crucial conversion point, preventing thrombin generation?
Exactly. They block the amplification right before thrombin takes over.
Right.
They're widely used now for stroke prevention and non-valvular atrial fibrillation, and for treatment and prevention of VTE.
Is there a common pharmacokinetic pathway that governs their interactions? This is key for the professional level.
Yes. Many of them, particularly rivaroxaban and apixaban, are substrates for two important systems: the drug efflux pump P-glycoprotein, PGP, and the metabolic enzyme CYP3A4.
Dual pathway, what does that mean for interactions?
It means they're vulnerable to drugs that strongly induce or inhibit both PGP and CYP3A4. For example, strong dual inducers like ravin-pen, carbamazepine, thanatorin, St. John's wort can significantly increase the clearance of these DOACs, potentially reducing their concentration and efficacy, leading to clot risk. Conversely, strong dual inhibitors like certain antifungals or protease inhibitors can increase DOAC levels and bleeding risk. Always check for these interactions.
Let's touch on a subtle clinical point: rivaroxaban versus apixaban dosing and potential advantages.
Rivaroxaban is often dosed once daily for atrial fibrillation and VTE treatment after an initial loading period, which can be an advantage for patient compliance. Apixaban is typically dosed twice daily. However, apixaban has generally shown favorable outcomes, including potentially lower bleeding rates in some studies, and might be preferred in patients with borderline or mildly impaired renal function, although dose adjustments are still needed based on specific criteria. It's often a trade-off discussion with the patient.
And betrixaban has a very specific, narrow indication, right?
Yes, betrixaban is unique. It's the only oral factor XA inhibitor approved solely for the prophylaxis prevention of VTE in acutely ill adult medical patients hospitalized for moderate or severe restricted mobility and other risk factors. It's not approved for treating active VTE or for AFib stroke prevention, a very specific niche.
Despite all the convenience of the DOACs, particularly the factor XA inhibitors, what remains their Achilles heel?
The main lingering concern has been the lack of widely available, specific, rapid-acting reversal agents, especially for the factor XI inhibitors, though this is changing. And another critical point: abrupt discontinuation of any DOAC without starting alternative anticoagulation is associated with an increased risk of rebound thrombotic events. You can't just stop them cold turkey without a plan.
Okay, final section. We've prevented clots. Now let's talk about actively destroying them with thrombolytics, and then how we reverse anticoagulation when bleeding occurs. The clot busters.
Thrombolytic drugs, or fibrinolytics, are reserved for emergency situations: acute MI, massive PE, acute ischemic stroke within a specific time window. Their job is to dissolve an existing clot.
How do they do that? They leverage the body's own clot-dissolving system.
Exactly. They work by activating the conversion of an inactive precursor, plasminogen, into the active enzyme plasmin, also called fibrinolysin. Plasmin is a protease that directly degrades fibrin, the protein mesh holding the clot together. Essentially, they chew up the clot.
What are the main agents we use?
Primarily recombinant forms of tissue plasminogen activator, TPA. The main ones are alteplase, activase, and tenecteplase, TNCase.
I remember alteplase being called fibrin selective. What does that mean practically?
At lower therapeutic doses, alteplase preferentially binds to plasminogen that is already bound to fibrin within the thrombus. This localizes the plasmin generation somewhat to the clot itself, rather than just activating all the free plasminogen circulating in the blood, which would lead to a more systemic olytic state and breakdown of circulating fibrinogen.
So potentially less systemic bleeding risk compared to older, non-selective agents.
Theoretically, yes, though bleeding is still the major risk. Tenecteplase is a genetically modified version of TPA. It has a longer half-life and even greater fibrin specificity than alteplase. The longer half-life is a big practical advantage because it allows tenecteplase to be given as a single weight-based IV bolus, whereas alteplase typically requires an initial bolus followed by a prolonged infusion over 1 to 3 hours.
Makes sense. The obvious downside of dissolving clots is
Massive bleeding risk. These drugs are powerful but indiscriminate. They can't tell the difference between the pathological thrombus causing a stroke and a necessary hemostatic plug sealing a recent wound or ulcer. Hemorrhage, particularly devastating intracranial hemorrhage, is the most significant danger. That's why there are very strict contraindications: recent surgery, history of hemorrhagic stroke, active bleeding, uncontrolled hypertension, etc.
And there's that unusual interaction with ACE inhibitors.
Yes, an important one to remember. Concomitant use of alteplase and potentially other TPAs with ACE inhibitors seems to increase the risk of developing angioedema, swelling of the face, lips, airway. The exact mechanism isn't fully clear, but might involve effects on bradykinin metabolism, which both drug classes can influence.
Okay, we've covered starting, stopping, and busting clots. Now, the critical final piece. The antidotes. How do we reverse anticoagulation when things go wrong? Let's synthesize this.
Mastering the reversal agents and strategies is absolutely essential. For good old unfractionated heparin, the antidote is protamine sulfate.
How does protamine work on a chemical level?
Protamine is a protein, originally derived from fish sperm actually, that is highly positively charged. Heparin is highly negatively charged. They have a strong electrostatic attraction. Protamine binds ionically to heparin, forming a stable, inactive complex, effectively neutralizing the heparin.
But the dosing is tricky.
It has to be carefully titrated, usually around 1 milligram of protamine per 100 units of heparin, estimated to still be circulating, based on time since last dose. Giving too much protamine is bad, because protamine itself, in excess, can act as a weak anticoagulant. It's also important to know that protamine only partially reverses the effects of LMWHs, mainly neutralizing the anti-IA activity more than the anti-ASA activity. It's not a complete reversal for LMWH.
Okay. And for warfarin?
The specific antidote is vitamin K1, fitinidone. It can be given orally or IV. But remember warfarin's mechanism, it stops the synthesis of active factors. Giving vitamin K allows the liver to start making new functional factors again, but this takes time.
How much time?
The response is inherently slow. You won't see a significant improvement in the INR for several hours, and it can take up to 24 hours or more for full reversal as new factors are synthesized. So if you need immediate reversal for life-threatening bleeding on warfarin, vitamin K alone isn't fast enough.
What do you do for immediate reversal then?
You need to give the factors themselves. This usually means administering fresh frozen plasma, FFP, which contains all the clotting factors, or more concentrated products like prothrombin complex concentrates, PCCs, which contain factors 2, 7, IX, and X.
Right. Now, the DOACs, dabigatran has a specific antidote.
Yes. Currently, dabigatran is unique among the commonly used DOACs in having a widely available specific reversal agent, idarucizumab, Praxbind.
What is it?
It's a humanized monoclonal antibody fragment designed specifically to bind to dabigatran and its active metabolites with extremely high affinity, much higher than dabigatran's affinity for thrombin. It rapidly and completely neutralizes dabigatran's anticoagulant effect. It's given IV and reserved for emergency situations like life-threatening bleeding or urgent surgery.
And the factors AGs inhibitors. The situation there is still evolving, right?
It is. While a specific reversal agent, andexanet alpha, is approved, its availability and use patterns are still developing. For severe bleeding with factors AD inhibitors, management often involves stopping the drug, supportive care, and sometimes using nonspecific procoagulant agents like PCCs, though their efficacy isn't as well established as specific reversal.
Okay. Finally, what about drugs that don't reverse anticoagulants but actually promote clotting or stabilize existing clots?
Those are the antifibrinolytic agents. They work opposite the thrombolytics. They prevent clots from being broken down too quickly. The main ones are aminocaproic acid, Amicar, and tranexamic acid, TXA.
How do they work?
They inhibit the activation of plasminogen to plasmin. By preventing plasmin formation, they prevent fibrinolysis or clot breakdown. Tranexamic acid is significantly more potent, about 10 times more so than aminocaproic acid.
And when are these used?
They're used in situations where excessive bleeding is due to excessive fibrinolysis, for example, controlling bleeding during certain types of surgery, like cardiac or orthopedic surgery, treating heavy menstrual bleeding, or managing bleeding in patients with inherited bleeding disorders like hemophilia. So if we try to synthesize this whole deep dive, we've really gone from the ground up. We looked at how platelets stick together, driven by things like TXA2 and ADP, leading to GPIB activation. Then we saw how aspirin, clopidogrel, ticagrelor, and the GPIB blockers take that apart. Then we moved to the cascade, factors AM making thrombin, thrombin making fibrin, and how heparins boost antithrombin III, while warfarin blocks vitamin K and the DOACs directly inhibit thrombin, or factors AM.
It's a complex interplay, definitely. So connecting all those molecular details, all those pharmacokinetic nuances, we discussed the CYP metabolism, the renal clearance. What's the real take-home message for achieving that elite professional understanding?
I think the mastery, the real so what, comes from connecting the dots. It's not just knowing that clopidogrel needs CYP2C19, but understanding why that means you need to check for PPI interactions or consider genetic testing in a patient with stent thrombosis. It's not just knowing LMWH is cleared by the kidneys, but internalizing why that means checking a creatinine level before prescribing it is a critical safety step to prevent potentially lethal bleeding from drug accumulation.
Right.
It's seeing how the pharmacokinetics, half-life, metabolism, excretion directly dictates the clinical practice. The need for monitoring, INR versus APTT versus none, the risk of interactions, the choice of reversal strategy, that ability to integrate the mechanism with the patient-specific factors in clinical context. That's the leap from just knowing facts to true professional judgment.
Which leads perfectly into a final thought for everyone listening. Consider the big picture trade-off we've witnessed with anticoagulation. We've largely shifted from drugs like warfarin and heparin effective, yes, but demanding intense monitoring and with readily available, albeit sometimes slow or imperfect, antidotes towards the DOACs, especially the factor ZAZ inhibitors.
The predictable ones.
Exactly. Much more convenient, predictable dosing, less monitoring hassle. But for years, that convenience came at the cost of increased vulnerability during a major bleeding event because we lacked those immediate specific reversal agents. Now, as reversal agents for factor ZAZ inhibitors like Andex and Alpha become more established, how does that change the equation? How will their availability, costs, and real-world effectiveness fundamentally reshape the risk-benefit assessment, the prescribing patterns, and maybe even the monitoring paradigms across all these classes of anticoagulants in the next decade? That ongoing evolution, that constant rebalancing of efficacy, safety, and practicality, that's the real high-wire act we're all navigating in hemostasis management.